This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Cochrane database of systematic reviews, published in 2026. It's a protocol for a systematic review titled Magnetic Resonance Spectroscopy, or MRS, for differentiating tumor recurrence from radiation necrosis in treated intra-axial brain tumors.
This is a topic that hits home for anyone who spends time in a neuro-oncology clinic. We've all been there. You have a patient with a high-grade glioma or perhaps a brain metastasis who underwent surgery and followed up with radiotherapy. 6 months later, the surveillance MRI shows a new or enlarging contrast-enhancing lesion.
Exactly, and that's the diagnostic challenge the authors Sodis and colleagues highlight. The clinical dilemma is whether we are looking at tumor recurrence or radiation necrosis. Both can look almost identical on conventional contrast-enhanced MRI.
And the stakes couldn't be higher. If it's recurrence, we might be looking at a change in chemotherapy or even a reoperation. If it's radiation necrosis, a form of radiation-induced injury to brain tissue, the management is entirely different. Treating necrosis as a recurrence could lead to unnecessary morbidity, while missing a recurrence could be fatal.
The paper notes that the reported incidence of radiation necrosis ranges widely, from 3% to as high as 68%. It can even present years after the initial treatment.
It's a broad range because it depends so much on the treatment modality. The authors provide a great breakdown of the modern radiotherapy landscape. They mention everything from external beam radiation therapy, EBRT, which includes 3D conformal radiotherapy, IMRT, and VMAT, to more focused approaches.
Right, and they specifically mention particle therapy, like protons, which are used to reduce the radiation dose to adjacent normal brain or critical structures, especially near the eloquent cortex, where surgical morbidity is high. They also touch on brachytherapy and, of course, stereotactic radiosurgery, or SRS.
SRS is where we often see this diagnostic headache, using gamma knife or cyber knife to deliver high-dose, highly focused radiation in 1 to 5 fractions. It offers excellent dose conformity, but the risk of radiation necrosis is always looming, especially as we re-irradiate selected patients.
The paper points out that conventional CE-MRI lacks sufficient specificity to reliably differentiate these two entities. Both can be asymptomatic, or both can present with neurological symptoms. To make matters even more complicated, the authors mention that both processes can even occur simultaneously in the same lesion.
Which is why we need more than just anatomy. We need physiology. That brings us to the intervention they are studying, Magnetic Resonance Spectroscopy, or MRS. Ilara, how does the paper define the role of MRS here?
The authors describe MRS and its mapping cousin, MR spectroscopic imaging, or MRSI, as a tool that enables the non-invasive quantification of brain metabolites. Essentially, it allows us to look at the biochemical profiles of the tissue. The idea is to differentiate viable tumor tissue from radiation-induced changes based on those metabolic signatures.
It's basically a virtual biopsy. While we've been using MRS in practice for years, the authors note something quite striking. Despite its promise, there is still no consensus regarding its accuracy, and it hasn't quite made it into official clinical guidelines or recommendations.
That's why this Cochrane review is so critical. Their primary objective is to determine the diagnostic accuracy of MRS specifically for detecting tumor recurrence or progression in patients with primary or secondary intra-axial brain tumors who have already undergone radiotherapy or radiosurgery.
I'm glad they are including both primary and secondary tumors. A metastasis behaves differently than a glioblastoma, and the treatment-related complications can look different. Did they mention how they plan to handle the differences in how MRS is actually performed?
Yes, that's one of their secondary objectives. They want to explore potential sources of heterogeneity. In this context, they aren't just talking about the patients, but the technical parameters of the MRS itself, the acquisition techniques. They also want to investigate if there are clinically meaningful diagnostic cutoffs or thresholds.
That's the holy grail for a resident or a busy attending. We want a number. Is the choline to creatine ratio above a certain threshold? Is the NAA low enough to suggest necrosis? The paper suggests that variations in the reference standard, whether that's a tissue biopsy or just clinical follow-up, can influence how well the test appears to perform in different studies.
Exactly. The reference standard is the gold standard we compare MRS against. In neurosurgery, a biopsy is the definitive answer, but as the authors note, biopsy has its own limitations in terms of feasibility and safety. You can't always biopsy a lesion in the brainstem or deep functional areas.
The authors emphasize that an accurate diagnosis at an early stage is of the utmost importance for timely interventions and changes in management plans. If we can trust MRS, we might avoid those repeated imaging sessions or more invasive PET scans.
It's also about morbidity and mortality. The paper mentions that identifying the correct underlying pathology is crucial because these two conditions have completely different types of treatment and outcomes.
I noticed the authors are from the Department of Neuroradiology at Karolinska and the University of Santiago de Chile. It's a very international effort. They seem very focused on the fact that developments in MRI technology have introduced these advanced functional and metabolic imaging techniques, yet we are still lacking that top-tier evidence synthesis to change daily practice.
Their protocol is very rigorous. They're looking for studies where the participants present with new or enlarging contrast-enhancing lesions, suggestive of recurrence. That is the exact clinical scenario where we struggle.
And it's not just about the tumor type. They're looking at the clinical choice of modality, factors like tumor size, location, histology, and even patient-related factors like performance status. They really want to see if MRS holds up across the board, whether it's an infiltrative glioma or a well-defined 3-centimeter metastasis treated with SRS.
One thing that stood out to me in the background section was the mention of malignant transformation of lower-grade tumors. MRS might be the key to seeing that shift before the clinical symptoms even start to manifest.
It's about being proactive rather than reactive. If we can use the biochemical profiles provided by MRS to catch a recurrence early, we might be able to offer salvage treatment with a higher expected therapeutic benefit.
So, to summarize the protocol's goal, they want to provide a definitive look at MRS accuracy to finally bridge the gap between showing promise and being a part of official clinical guidelines.
It's a necessary step. As surgeons, we rely on our radiology colleagues to help us navigate these treatment-related complications. If this Cochrane review provides a clear diagnostic threshold, it could change our workflow in the multidisciplinary team meetings.
We will definitely be keeping an eye out for the full results once the review is completed. It could very well settle the debate on how we manage these enhancing lesions once and for all.
Absolutely. Well, that's all the time we have for today's deep dive. Thank you for joining us on the Neurosurgery Hub podcast.
We'll see you in the next episode.